I'm Jennifer Kennedy, the lead for compliance and quality at CHAP, and welcome to this edition of CHAPcast. So, what we're going to be talking about today is medication reconciliation. And I'm so glad to be back in the podcast saddle with my sidekick and friend and colleague, Kim Skian. And Kim, you know what? I think this topic is always timely, and it is such a big deal in order to get MedRec correct. So let's just go ahead and jump right into it, unless you have any pre-thoughts that you want to throw out there to our listeners before we jump into it.
Absolutely. And the only thing that I'm thinking is, we're seasoned home health and hospice and RNs, we'll say that after, 4 decades or so. And in the entire time, in the entire time that we have been certainly in this industry, probably long before that. And since then, every clinician in every setting faces this issue. This medication reconciliation issue is just so important. And it's something that, as you said, is really timely and timeless. So I think this is really a great topic for today. So thanks for having me.
Absolutely. So Kim, why do clinicians and organizations need to pay attention to this? Why does it matter so much?
Well, first and foremost, remember that this really reflects and targets patient health and safety. Patient safety is paramount. And over the many years, with progression with medications, so many medications on the market, so many different medications, cross-setting with different settings that the patient may be visiting or being cared for, really can result in a lot of confusion and, frankly, danger, for the patient if there are issues that are not addressed in terms of medications, duplication, omissions, lack of clarity, all of those areas. So it really is crucial. The medication reconciliation process is crucial to ensure that the safe and effective use of medications is being reviewed, identified, and resolved. At the time of assessment, not just, and we'll talk about this, I know, not just at the time of initial assessment, but ongoing throughout care.
Yeah, that's exactly it. And, you know me, Kim, I do a lot of reading. I read a lot of articles and things of that nature. And with our older adults wanting to age in place, stay at home, receive home services, it doesn't mean that they're necessarily going to have the capacity mentally to manage medications, especially if they're seeing multiple physicians. Each physician is prescribing, and maybe they don't have a caregiver to help them out with that. I feel like the continuum of healthcare that some older adults are experiencing absolutely could lead to safety issues around taking their medicines. So, and I just stated myself by saying their medicines. I know that. But you're right. I mean, it's so much a safety issue. And I know both you and I are no stranger of going on a home visit and saying, show me all your medications. And they put a big old shopping bag on the kitchen table and you're, taking 30 minutes to sort through everything, Vicodin from 1973, all that, right? So, it's huge. It's huge. And, there are, I think, really some big questions that organizations need to be asking, about, the importance of requiring consistent medication reconciliation from their clinicians.
Yep, absolutely. And from a survey standpoint, again, medication discrepancies between the documentation in the home, what the patient's taking, the medication profile, physician orders, And if in a case of a patient serviced in a facility, such as for hospice, but also ALF, assisted living facility for home health, for example, if you don't have that, the alignment, that is one of our top survey deficiencies, not just for CHAP, but for all of CMS as well, all CMS state agencies, when we look at all of the top deficiencies. And the other component here is that it also, depending on the type of discrepancy and or the actual or potential impact on the patient, it can be certainly a condition level deficiency, but also immediate jeopardy. When patient safety is at risk, and then medications are at stake or involved. So that's why this is another reason why, in addition to patient safety, organizations need to understand how important this is for clinical practice and for compliance.
So the act of, nurse, whether it's you or me or somebody else, going into somebody's home, taking that time to take the medication list. Let's say it's an admission and you have maybe a discharge summary from a hospital, and you're taking that list and matching up against what the patient has in the house. And then maybe you're finding more things, herbals and nutraceuticals and, recreational marijuana is a thing now. All of those things have to be looked at in order to make an adequate and complete drug list. And you know what? I think the question that, particularly in hospice, that has come up for me in my career is people asking, hey, if we're not facilitating the prescription, or in hospice's case, providing the drug, does it go on the drug list? And the answer is yes. Even though you're not paying for it or supplying it, it absolutely has to go on that list, because that's the only way you're going to be able to see the scope, I think, of what that patient is actually taking, for sure.
Absolutely. Yep. And that does apply hospice, home health, really any setting. And also I would add that, as I said, it's not just the initial assessment, although we know that certainly in home health, there's the timeline to be in OASIS to be reconciling those medications with the physician. But that's a standard of practice. So any discrepancies need to be clarified with the physician, the prescribing physician, at the time of identification, but not forgetting that medication reconciliation is an ongoing process. And you and I both know, and we've said it many times, as have others, that really a best practice recommendation is for the primary care clinician. So most often that's an RN. But we also may have home health where there may be a therapist, a physical therapist,
right,
to at least make sure that the medications align all together, as I said, with the documents in the home, what the patient's taking, and and the med profile and the orders, and many times, I'd say probably most commonly during home visits, during a survey, when that question is asked, when the surveyor or site visitor in our case has the nurse conduct a medication reconciliation, there's very often a discrepancy, because the question that had been asked prior to that, the surveyor coming would have been the clinician asking the patient, have you had any med changes since my last visit? And of course the patient's going to say no, if they, don't think about an over-the-counter medication they took, or an adjustment to Lasix, for example, or another med that happened, a month or two ago. So it's really important to make sure that that your organization, hospice, home health, home care, honestly, home care if you're providing skilled care, making sure that there is a regular process for evaluating and updating those medications.
Yeah, I couldn't agree more. And when we're looking at, particularly, again, with the older adults, whether they're receiving home health or hospice or home care, getting that list, that complete list, in order to show it to either the primary care physician or the hospice doc or the pharmacist, so that they can look at things like drug interactions, or maybe see drugs that are on the Beers list that might, could be knocked out for older adults because it's a safety issue. And, some herbal medicines don't gel with prescription medicines. So having that complete list for that next intensive review of the drugs is really critical, because then we can proactively not have any kind of drug problems if that is completed in the right way. And I agree with you. I think it's every visit. That's standard practice. We know that either people sneak away to the doctor and they forget to tell us, or they have a family member that says, here, I saw this Nuriva on TV and Mom, you should be taking this, and all of those things. So it's not only a safety issue, it's really a quality of life issue as well, because you want your patient to feel good, either in their recovery period with you, if you're providing those kinds of services, or that they're comfortable if they're at end of life. So I feel pretty passionate about this issue, and I think maybe organizations out there may need to put this on as an evaluation, maybe for a performance improvement project, if they're not getting a handle on it. So
I agree with that completely.
Yeah.
Mm-hmm.
So Kim, when we talk about home health specifically, what would you say are some of the benefits of doing good, consistent MedRec?
Well, first and foremost, ensuring accuracy of the medications, of the medication list, and understanding the medications that the patient is taking. And I know, again, I'm using medications, but whether it's prescription, non-prescription, as you said, or herbal remedies, so that we have a true understanding of whether, what the patient's taking, to your point, what may need to be reported to the physician in terms of potential polypharmacy, interactions, contraindications. But really, it's part of the comprehensive assessment, evaluating patient needs, both on initial assessment or initial comprehensive assessment and ongoing, to make sure that we're looking at the appropriateness and the effectiveness of those prescribed medications, monitoring that adherence, especially when we're teaching on meds or there are med changes, to make sure that we that the clinician is assessing again the effect, and also the patient education to patients and caregivers, giving information about medications, and including dosages, side effects, for example, but also there are some other resources. You mentioned the Beers criteria, but there also are, it includes resources for help in terms of patient guides, as well as the Institute for Safe Medication Practices. So, agencies, hospice, home health agencies need to make sure, as well as hospices, need to make sure that they have those updated resources, and that their staff have updated information. And the other reminder, again, I alluded to it before, but related to home health specifically, when the home health conditions of participation were Appendix B was updated in revised April of 2024, they removed the line in the interpretive guidelines that stated that an RN or a qualified nurse needed to review any medication reviews or assessments, medication lists that were provided by a therapist. So the organization defines, based on state scope of practice, state regulation, and agency policy, what the medication review process is. And there still may be a process, for the organization may choose to have an RN or a nurse, conduct the further follow-up if there's a question, but the agency does have the ability to be able to determine the best way to make sure that information is updated ongoing, and that's the most important aspect of med reconciliation.
Absolutely. And, I thought of one other thing, although I know we don't want to go down this rabbit hole on this podcast, is that in addition, one thing you could learn from doing consistent MedRac is, if a patient is taking narcotic medications, if there's any kind of drug diversion happening in the home, that could actually be something discovered through consistent MedRac as well. That's a whole nother podcast, I'm thinking, Kim. I don't know about you.
Yeah. Mm-hmm. Yeah. Mm-hmm.
All right.
I agree.
So, when we're talking about what providers should be doing, there's a list of questions that I think about as a nurse that are related to medication reconciliation. I'm sure you're thinking about a similar list as well. And what are some of those questions that nurses should be asking if they're the primary person doing that MedRac on visits?
Well, again, first of all, making sure that they are evaluating and reviewing all of the medications that the patient is taking, even if that's an as needed, a PRN medication, we have to make sure that we know the medications that the patient is taking. If they're not taking medications, in other words, like you said, the, Vicodin from 1973, again, making sure that we're, working with them, confirming with the physician, but working with them, with the patient to educate them on drug disposal, safe drug disposal, so that they can clean up all of the old medications. We know many patients, especially older patients, have penicillin or, antibiotics or pain medications, not because they're stocking up for narcotic use, but because it's just in case I need it. So, we really have to differentiate to be able to make sure that we're clear on what the patient is taking, and also educate on safe medical practices, medication practices. So, in looking at not just the med list, it's the med list in the home, the actual drugs in the home, medications, and as well as, again, what's ordered, to look at the whole picture, and making sure that the patient and patient and caregivers, if they have them, understand their medications and can safely administer their medications. Because we also know that if patients are, or caregivers sometimes, if they're responsible for, administering their own medications or pre-filling medications, assessing to make sure that that all parties have an understanding of, what they're supposed to be, pre-pouring or administering, and at what times, and not, because we've definitely seen issues with that in terms of over medication or under medication because of a lack of understanding. Also, again, making sure that there are adequate medications on hand. Do they have enough medications? And this is, prescription or non-prescription, if they're regularly taking them. And we know for hospice, we order through the pharmacy, right, through hospice. But for home health, you want to make sure that you're working with the patient and family to make sure that they are ahead of the medication need. Also, as part of patient and family education, what are some of the alternatives for receiving medications? So if you have a patient who has dementia or has some sort of memory impairment, or cannot get out of the home, then having medication delivery services, or the pre-filled medication boxes, or the electronic dispensing in the home. There are so many opportunities these days with technology that we as clinicians need to first and foremost make sure we know what medications the patient's taking, but then on top of that, identify the best way for them to be able to get the medications that they need.
Yeah, there's one thing that stuck with me. You're talking about educating the patient and the caregiver or the family member. And we all know that that's really important, particularly if the patient doesn't have mental capacity. But we have to figure out how they best learn. And give the information, I think, in multi-mediums. We're going to tell them, we're going to give them something in writing, and we have to consider health literacy and actual literacy issues you just can't say, here's the sheet, right? You have to do a little more than here's the sheet about your medicine. Suggesting that someone does go with that patient to their appointments and things of that nature. So it's talking about individualizing that portion of the plan of care, even a little bit more than just saying, take this at this time on this day, and here's the education sheet about it. I think we need to be more thoughtful as providers to how people best learn, and making that a good match for them as well.
And Jennifer, I would also add that that any sort of education does need to be provided in a language or a method that the patient and family understand. So if it's a foreign language, or hearing impaired or sight impaired, to be able to make sure that the people who are receiving the education and the training understand that, comprehend. And also, I think you have a great reminder about, one of the key, I think, components of education, in addition to safe storage and making sure they have the right medications and the purpose of the meds, et cetera, signs and symptoms of side effects, for example. But one of the big things is also making sure that whenever they are with another practitioner, whether it's a transition to an ER or it's to the any of their physicians or, practitioners that they're seeing, to make sure that they have a current medication list with them. Because, they want to make sure that the patient, that the clinician or whatever setting the patient is being seen in has an accurate description. And I know in this day and age, health systems have, charts, electronic charts that speak across the different settings, but you may be in a setting outside of the, of that particular enclosed health system, or if even though it's accessible to the clinician in the healthcare system, the patient may not have a true understanding of what they're actually taking. So having an actual written list taken with them to their appointments or any transition of care, I think is extremely important.
Yeah, can't recommend that enough. Absolutely. So, Kim, as we get to the end of our MedRec discussion today, are there any thoughts that you want to finish out with on this topic, or any epiphanies or anything that comes to mind for our listeners out there?
Jennifer, I think this is another topic that, you and I, and certainly many people in our industry, could have a far more lengthy discussion on, because it is so important. And I think just keeping in mind that our primary focus, again, is the health and safety of patients, and remembering that medications is a key element of that, of caring for these patients. So just I feel like there are resources and certainly these reminders that are very helpful, but each organization and each clinician needs to have a clear understanding of what their role is and how important it is to ensure patients' medications are accurate.
And I'm really excited that that you and I developed our medication reconciliation resource recently, and that we're going to be pushing that out the door shortly. Talk about multimedia. So we're doing the podcast, and then we're going to push out a written resource for our customers as well. So thanks for working on that with me, and hopefully we'll do some additional medication resources down the line. But I think that one will help whether you're a seasoned clinician, whether you're a new clinician. It's basically the basics of medication reconciliation. So look for that soon. We'll be posting that out on our webpage. Well, thank you, Kim, so much for talking with me today about medication reconciliation. I know that we could probably talk an hour more and tell some good stories about things we've seen in our almost 4 decades of nursing practice. And I think this one is, it's not a heavy lift to do, and it's so important. And we just have to make sure that we take the time in every visit to pay attention to that so that our patients remain safe and have good quality of life. So thank you to all of you for taking time out of your day to listen to our podcast about medication reconciliation. From Kim, me, and the entire CHAP staff, keep your quality needle moving forward, stay safe and well, and thanks for all you do.